All good. Awesome. Well, thanks so much, everyone, for coming to see our presentation today. We're going to talk about equitable pharmacogenomic, referred to as PGX, implementation in underserved populations. So let's get started. We don't have any disclosures, so we'll just kind of skip that. And as this, maybe some of you are well aware, pharmacogenetic testing, PGX testing, is used to optimize medication prescribing based on a patient's genetics. However, the problem is PGX is not equally accessible for everyone. Inequitable distribution of innovative healthcare technologies further exacerbates already existing healthcare disparities. Our most vulnerable patients are unable to receive the best quality of care. And so this discussion will talk about who those populations are, what barriers to PGX implementation there are for these underserved patients, and the strategies we can use to potentially mitigate the inequities. And then we'll also discuss efforts we've made at the University of Montana to ensure PGX access for rural, tribal, and other underserved communities here. So first, before I kind of get into the lesson, I want to introduce kind of our institute and what our model looks like at the Skaggs School of Pharmacy at the University of Montana. Our mission at the LS Skaggs Institute for Health Innovation, which I'll refer to as SciHi, is to be a statewide hub for health education, research, and outreach to improve access to emerging health innovations for underserved patients. We aim to improve equitable access to health innovations through our already established clinical programs. And these programs involve multiple initiatives. We have iPharm, which provides free health screenings to rural populations across the state. We have an MTM center that provides medication optimization counseling to patients and providers. We have an antimicrobial stewardship program that serves hospitals all across Montana. And we also house a comprehensive pharmacogenomics program aimed at providing PGX consultations and education, particularly for rural and tribal communities. And so we're going to center on the collaborative case between the MTM Center and PGX program during the patient presentation, which Jade will present later. So it is really exciting. PGX use is expanding. It's clear, however, there is an inequity in access due to barriers unique to different patient populations. Today, I'm just going to focus on a few examples of underserved populations that are prevalent in our state of Montana and who experience inequitable access to PGX. And I'll discuss tribal populations, patients who live in rural areas, as well as patients who classify into like a low socioeconomic status category. But before I get too deep in the weeds, I kind of want to ask you all, what do you think are the greatest challenges to testing implementation for rural and underserved populations? You can either unmute yourself or feel free to just comment in the chat, and we can take a minute to do that.
Yeah, if you have any, if you have an answer for this question for Shayna, put it in chat, or you can just speak up too. All right, there's one that says from Ben Duong, says collecting samples remotely.
Yeah, that's
lack
I can
of
definitely
services,
see that being difficult.
cost of test, access to a laboratory, trust, awareness.
Yeah, these are all great answers, and we will talk about a few of these in the presentation. So thanks for sharing. Perfect. We will.
There's a lot of there's more comments in there now.
Oh, great.
So maybe we can touch on all of these at some point.
Absolutely. Okay. Yeah, so just keep these in mind as we go through the rest of the presentation and the patient case on what kind of barriers, it's not just Montana, but across the US that these underserved populations face. Great, thanks for participating, everybody. Okay, so first we're going to kind of talk about a diverse patient population, some minority groups, which are unfortunately not well represented in genomic research. So groups like CPIC, they rely on published data to make dosing recommendations for specific genetic variants, but variants that are underrepresented in published pharmacogenetic studies may not be sufficiently characterized to reliably predict how they can affect a drug's response. This figure here shows individuals recruited for a genome-wide association study globally, and they're separated out with these colors by ancestry. And there have been many efforts, maybe even some people on this call, who have done work to be more inclusive in research recruitment, but unfortunately, most of these studies have predominantly included participants of European descent, which is seen in this red kind of spike here, which obviously is not representative of the global population. It's maybe like a sixth. And you can see with the other colors, populations that are not of European ancestry are greatly underrepresented. The blue portion, which represents East Asian ancestry, has grown slightly over the past 5 years, which shows significant promise, but the representation is still not reflective of the global population seen here. This misrepresentation is especially true for Indigenous populations, which don't even register on this figure out of its Nature Medicine. And globally, Indigenous populations do make up less than 0.02% of GWAS studies. Due to historical traumas and past harms, through research efforts, many Indigenous groups are hesitant to participate in recruitment initiatives. And so moving on to rural patients, this figure shows population density by county in the US. The red and orange counties are large metropolitan areas. The lighter orange and yellow are small metropolitan areas, and then their light green and dark green areas are micropolitan and rural areas, respectively. You can see Montana's up here. The majority of specialty care, like PGX, reside in these red and orange areas, and patients living here have just more access to large academic centers, more options for specialty care, and greater diffusion of newer healthcare innovation. And you can see Montana is mostly rural. Of the 56 counties in Montana, 55 are considered healthcare provider shortage areas, and that's just primary care. Access to specialty care is even further out of reach for many patients. And so they have to travel long distances to metropolitan hubs like Seattle or Denver or the Twin Cities for specialty options. And geographically remote patients already suffer from increased healthcare burdens, and a lack of access to any innovative technology like PGX further exacerbates the health inequities faced in these communities. Montana is home to just we only have a little over 1 million people here. And on this map, you can see only a few counties representing more than 50,000 residents. That's the dark purplish here. There's Great Falls, and then Missoula, we're located right over here. The light purple counties are populations between 10 and 50,000, and the majority of Montana counties are designated in white, which hold less than 10,000 residents, and some of them much less. Additionally, there are 12 tribal nations spanned across 7 federally designated reservations, and these are the outlines in dark purple, as here and here. As you can see, a large portion of Montana reservations are also in rural areas. Additionally, patients experiencing homelessness who are uninsured or underinsured or living in poverty are at a significant disadvantage because pharmacogenetic testing is still relatively expensive. Someone had mentioned cost. And yeah, that's a significant barrier. Approximately 15% of Montanans live below the poverty line, and counties that overlap with reservations, unfortunately, report higher poverty rates. The Flathead Reservation, which is in the maroon circle here, overlaps with Lake and Sanders County, which are both rural, and they report a significantly high poverty rate of 23%. So in Montana, these patients have multiple barriers preventing access to PGX resources. And I would like to point out, these aren't the only underserved populations in Montana or across the US. These are just the few that I'm going to focus on. So if a tribally enrolled underinsured patient living in Hot Springs, which is in Sanders County and also located on the Flathead Reservation, wants to access a PGX test for, let's say, depression medication selection, we are one of the very few programs in the state actively implementing, and we're down here in Missoula. And so they would need to travel 80 or more miles to reach not only one of the closest mental health providers to order the test, and the cost of transportation for any appointments, the test cost, it would all be a significant barrier to this patient. So the likelihood of them receiving a PGX test and subsequent consultation is very slim. So we really wanted to address these inequities of PGX testing in Montana. My PI, Dr. Erica Woodall, who's on the call, and our team established partnerships with 3 early adopter sites to kind of address this inequitable access. The Confederated Salish and Kootenai Tribal Health Department is in St. Ignatius, which they're located on the aforementioned Flathead Indian Reservation. Partnership Health Center, a federally qualified health center, is located here in Missoula, which provides care to underserved patients living below the poverty line or experiencing homelessness. And then we have Shodair Children's Hospital, the primary children's inpatient psychiatric facility and the only clinical genetics department in the entire state. They serve patients all across Montana, and they offer inpatient and outpatient services. And they do have outpatient clinics in a few different spots around the state. And each of these sites serves a unique patient population that historically has been disenfranchised. So to gauge barriers and facilitators to implementation at these sites, we conducted interviews with stakeholders, and I'll show you some of the data that we've gathered from this project. We found common concerns among the site, including many that are represented in other implementation studies. These included issues surrounding reimbursement strategy. We talked about testing costs, long test turnaround time, so access and getting the tests back, struggles with EHR or electronic health record integration, and many participants, and these were providers, a lot of them, expressed that testing may fall outside their area of expertise, and they would need training and educational opportunities in order to utilize the test and provide proper prescribing recommendations for patients. However, even if participants were unfamiliar with PGX, they were really eager to learn more, and each site held specific concerns with implementation that highlighted the unique needs of their underserved patient population. We'll start with the Confederated Salish and Kootenai Tribes, or CSKT, Tribal Health Department, which reflected distrust of genetic testing and research due to historical injustices, understandably, and a desire to be transparent about research and testing capability. So one provider stated, "I think the risks that are known to me, especially when you're talking about inclusion and equity and diversity, is that sometimes when researchers come in and explain this might be the benefit, it still feels pretty attacking if it's not necessarily a grassroots recognition of need." As I mentioned before, American Indian, Alaskan Native people have largely been underrepresented in all research studies, not just genetics. And providers working at CSKT Tribal Health felt PGX platforms may not include relevant variants to CSKT patients. So if testing was offered for patients, they would need to ensure the testing platform was developed based on research done with American Indian, Alaskan Native people. And I will note our lab here in Sci-Hi at the Woodall Lab has been working with CSKT for the past 16 years to better understand PGX variation in American Indian, Alaska Native people. And even with these concerns, the participants felt PGX could have a large impact on patients in their community, and they were really open to learning more about it. Next was Partnership Health Center. Expressed concern for ensuring equitable care for their patients. They're a federally qualified health center, and they treat patients kind of all across those who are houseless, in poverty, etc. And they explain that they often prioritize treatment strategies differently based on these factors. And one participant stated, "That has always been my hesitancy with precision medicine. In theory, it's fantastic, but precision comes with a cost. And if that service is not being distributed equitably, then you're just adding to an existing problem." Participants wanted to ensure programs were accessible by every patient and not just patients who could afford the test or who had insurance that could cover it. They also emphasized providers there have a big concern with time burden and click fatigue, which means providers are constantly given reminders and pop-up windows in the EHR, so they may ignore or miss important notifications. But many of them reported implementing PGX would align with the vision of partnership, and they were really eager to offer some sort of service to their patients if it was possible. Last was Schroeder Children's Hospital, which referenced a lack of adequate education surrounding PGX and struggles with test integration into the workflow during prior attempts. They had a unique perspective because they used PGX testing in the past when it was kind of brand new, and they had clear goals and expectations for any future implementation efforts. They felt PGX could fill gaps in care for psychiatric pediatric patients in a state where there's often limited access to mental health services. And many participants were especially interested in using telehealth as a platform, which they already use in their clinical genetics department and their outpatient services. I feel like this quote really captivated this theme well, where one of the things that I'm kind of intrigued by is we're starting to develop outpatient telemedicine and the ability to discharge and manage kids, and specifically to manage their meds. If we could pair that with pharmacogenetic testing, that becomes a pretty powerful service to offer a rural state. So these results led us to understand the needs of underserved communities in Montana and develop a UM-centric PGX program driven through a telehealth technology. PGX expertise and consultations are conducted by experts and pharmacists at with providers, patients, and even their families. Education resources are also continuously available to patients and providers, and we even developed an educational video not too long ago, and that can be found on our website if you're interested in seeing that. So to assess the successes and pitfalls of this approach, we are currently evaluating provider uptake, utilization of the test, and consultations. And so we're gathering data on clinical intervention metrics through post and consultation and quarterly surveys. And we're also evaluating patient and family satisfaction with the program to evaluate that accessibility. We really hope to expand our program across Montana, serving all sorts of disenfranchised populations. We really want to ensure equitable access to PGX testing is available to all patients, regardless of ancestry, geographic remoteness, or socioeconomic status. These are my acknowledgements.